Well, Dr. Yaya Desu, Head of Risk Communications Division, NCDC, joins us this morning to speak specifically about the outbreak of yellow fever and a number of other such issues that we are confronting along with COVID-19. Thank you very much, Dr. Desu, for joining us this morning. Well, your agency, the NCDC, put out that information that we haven't had yellow fever outbreak in 21 years until September 2017. And we have been having talks since that time that there is need for us to have another mass vaccination program for yellow fever. At what point did we drop the ball in those 21 years?
Thank you very much for having me. I will tell you that it may not be that we are not having cases. Definitely, it might have drastically reduced. It's because in recent times, we have scaled up our surveillance system, our ability to detect these diseases in the country. And that's how we could pick monkeypox and more cases of Lassa fever. So it could be a function of a functional surveillance system. So I think that is will be what accounts for this. And actually, if we really have a very high number of cases, and these are deaths that you cannot hide. But you have had instances in the past where you just hear strange deaths, strange illnesses in some communities, which may be yellow fever, probably because we could not diagnose it at that time. We could not pick it in the community. And our community are more aware of reporting. Particularly after Ebola outbreak in the country, the awareness was raised, and then people now know that there are conditions called viral hemorrhagic fever, which are categories of illnesses that are related, are caused by certain types of viruses, which include yellow fever, Ebola, Lassa fever, dengue fever, and so on. So even the community now, because of Ebola at that time, when they see strange illnesses, they want to report, they want to cry out. And then the healthcare workers too, there is some index of suspicion that has increased. And then with the coming up of NCDC that is particularly focused on this, and the NCDC has also been doing a lot to improve our laboratory capacity, then the capacity to do contact tracing, surveillance, all those things are things that have really contributed to cases that we are identifying now. They could have been identified as disease of unknown origin, or maybe one spiritual attack in one community. And these are what we used to describe them as in the past. So that might be what is happening. It's not that we dropped the ball, but it's like we're improving. And there is also this global awareness. It's a global village. Healthcare system too is also improving globally. There is a better connection between countries. WHO, we have what we call IHR. There is more awareness about it, and to make sure that this works better, then global health security agenda, and so on and so forth. So all these play a role to help us in detecting these cases. And then again, our vaccination campaign.
Well, we'll get to that, Dr. Odisu, but when you say that there have been certain outbreaks that we didn't pay attention to that could have been yellow fever, we also remember that earlier on, while we were combating COVID-19, there was some kind of outbreak in the north where we have hundreds of people were reported to have died. Was that yellow fever?
Those outbreaks, when they were investigated, I don't know which one you are referring to in particular, but many of them turned out to be yellow fever. You can remember, I don't know what year you're talking about.
No, it was this year, Dr. Disu. No, it was this year. Just a moment. It was this year while we were talking about COVID-19 before it really got, I think it was around March, April or thereabout, when before the complete lockdown of everywhere started, we had outbreaks, I think, in Gombe and then maybe Kano, a number of other states in the north. And it was said that, no, it wasn't COVID-19, but whatever it was strange that we didn't know about it. So I was wondering, when you said that maybe we had outbreaks that we didn't pay attention to, maybe that was yellow fever, but we didn't diagnose it right.
But if you actually check the CTREP of Nigeria Center for Disease Control, as of January, it was reported that we had outbreaks of yellow fever in the country, in many states. States that have not reported cases were reporting cases for the first time. And this actually started last year, not just this year. So the CTREP still captured that. And that was why there were plans to do mass vaccination campaign and then some other interventions to ensure that we are better prepared for this. But with the COVID-19, I think attention shifted, not just the health system in the country, even the people, political class, everybody just focused on COVID-19 because of its global nature, and then it was a novel virus or novel outbreak that we probably didn't know, and we're still battling with till date.
Dr. Disu, when we asked the other time at what point we dropped the ball, and you said we didn't drop the ball, I need some understanding. Because just as we noted, since like 1996 or thereabout, we didn't have a single case of COVID-19, of yellow fever. It was not reported. There was no outbreak or whatever it is. Not a single case, according to the release put up on NCDC website. And then in 2017, it started. What were we doing before 2017 that we stopped doing, which led to this outbreak?
Okay. When you look at the whole country, when you look at the budget that is allocated to the health system, and then since I think 1988 was the time we have a widespread outbreak of yellow fever in the country, and attention was drawn. And then over time, the budgetary allocation to the health sector has been declining. And it is from the proportion of what comes to the health sector that you can now see what part of it will also come for preventive activities. And then again, our diagnostic capacity, you remember we also experienced a lot of brain drain, people leaving the country, and those things could have count for why our healthcare system is in the state where we are now. Investment in facilities, in laboratory facilities, in our hospitals, ability to detect and then treat these cases, and then also motivation of the healthcare workers, issue of infection prevention and control. And so in general, decline in the quality of service in the healthcare system could be the reason why we fail to pick those cases. And now that we're coming up again, public health awareness, particularly after Ebola outbreak in the country, people are afraid, nobody wants Ebola again. Because when you talk about surveillance, it starts with the people. People that come to
Dr.
report.
Disu,
It is when people report.
there's something that we need to understand here.
Will not be able to.
Just a moment, Dr. Disu. Yellow fever is vaccine preventable. You take it once in a lifetime. Did we stop vaccinating before 2017?
Then you will remember that our vaccination strategy in Nigeria, yellow fever is part of the routine immunization, and which means everybody, the time that campaign was started, if everybody gets that vaccine, by now, everybody should be protected. But so it also shows the failure of our routine immunization. I know that MPACDA will be in a better position to tell us the true picture of our vaccination status in the country, how it has declined over time, and what efforts have been made to improve on that. So it still goes back to the fact that part of the strategy to prevent yellow fever, there's what we call I strategy, eliminating yellow fever epidemics. Vaccination mass campaign is also part of it. Strong surveillance system to be able to detect it, ability to respond when you even detect, and then also prevention, environmental sanitation, cleaning. And these are things that if you look at all these areas, there has been tremendous decline in the country in the past few decades. Maybe with this awareness and with intersectoral collaboration, interagency partnership, MPACDA, NCDC, and other agencies working together, and then even National Orientation Agency to also drive awareness in the community, probably we will get it again.
Well, it's very interesting the things that you have just said now, Dr. Disu, but I understand that your partner, just as you said, from NPHCDA has just recently joined us in this conversation. But we'll take a break now, and when we return, we'll be able to deal with these other issues. Please stay with us. Thanks for staying with us. Dr. Basio Pose, Director, Disease Control and Immunization, National Primary Healthcare Development Agency, joins us next in Abuja studio. Thank you for joining us this morning. Kadi.
Well, Dr. Bassi.
Good morning. Thank you. Good morning, Nigerians.
Good morning to you too. Well, we just listened to that report, and apparently they've still not sorted out some of those illnesses. It still appears strange to them. But you hear, health experts say, well, it's not really strange. It's probably yet to be diagnosed. And I know that you have a major responsibility in this surveillance response. And the big question is, yes, regarding yellow fever, which we have seen across some states, and now this one that is being called strange. What kind of surveillance really does your agency have across local government grassroots, such that we don't describe these things as strange? We can say, well, we're on top of it, we saw this coming, and this is what we're doing about it.
Okay. I think Nigerians will be right to call it strange at the point that they don't know exactly what the disease is, because there are so many things, or so many conditions that will present like that. For the particular cases at point now that is in discussion, where we have in Ika Northeast local government in Delta State, the same report we got from there. And this week that we are in also, we've got the report from Enugu, from the Igbo is a local government, not local government, where they describe it as strange also. But interestingly, in each of these two instances that have been reported, the initial laboratory confirmation shows that these cases are yellow fever. At least we know what the cases are. With regards to the earlier question that you asked, the surveillance system we have in the country, in all the local government areas, we have the DSNOs that are responsible for notification, where once a disease is that is notifiable, they see the signs, they report immediately through the structures that we have. It's through these surveillance structures that we are able to pick these diseases that are being reported currently. And like mentioned earlier, it is not as strange as mentioned, because the initial confirmation shows they are yellow fever from what we have from the specialist hospital, Irua. Now the final stage is awaiting the yellow fever confirmation from the lab in Senegal, which will be the final confirmation. So with regards to what we have on ground, we know it is yellow fever, and interventions are already ongoing in these states that are involved. Over.
Right. For over 21 years, Nigeria did not report any case of yellow fever until 2017, when that case was reported in Kwara State. And we've since seen that yellow fever spread across other states in the country. And I mean, we were speaking with the NCDC official, Dr. Disu, much earlier, and he says that, well, regarding vaccination, maybe surveillance, I mean, you have a major role to play. So what happened, really? How did we get to that point where we moved from Kwara, just Kwara, to a lot more states, in fact, states that didn't share any border with Kwara State? So what exactly happened?
Okay. You see, I want to use this opportunity to thank the government of the day and all our partners for the support, because I'm sure if not the support and the leadership we have through His Excellency the President, the Minister, Professor Ehanire, and then the Executive Director of the agency, Dr. Faisal Shwal, if not the responses and the support we are having, I'm sure probably it would have been worse than this. We had expected this, and the country was not resting. In 2013, we started a response. We wanted to immunize all Nigerians against yellow fever. But unfortunately, the limitation had been the availability of the global vaccine. So in 2013, we were only able to have vaccines that could cover 3 states of Cross River, Akwa Ibom, and Nasarawa State. That was in 2013, early 2014. And since then, we also could not get enough vaccine aside the ones that are used for the routine immunization of our children, which of course is always available. Nigeria is the only country in Africa that has this vaccination bought by the government and given to all the eligible children under 2 years free of charge. And when you look at the incidences that we're having for now, you are not seeing the cases among those age group. The incidence we are seeing in Enugu is between the age group of 18 and 30 years. In Delta State, between the 18 and 25 years maximum of age. You can see they are among the older age group. The children have been adequately vaccinated because the government provides free of charge. But those other adults that don't have the vaccination majorly is because we wanted to respond nationally, but the vaccines have not been available to accommodate every Nigerian apart from the one that is available routinely. It's not that the country is ready to buy to be able to vaccinate, but the production is not enough to do that. So in 2013, 2014, we had enough that could vaccinate in 3 states, as mentioned earlier. Early 2018, the vaccination could cover 6 more states of Kwara, Kogi, Niger, and we also had Zamfara, and then Borno State. And that was in an FCT in 2018 early. November 2018, we also had another 2 sets of states. In 2019, we had a campaign in Katsina based on the vaccine that was available. And then early this year, there was also vaccination in Rivers State and Sokoto. As we are planning, even before this outbreak, we were to start around June vaccination in 6 other states, Delta inclusive. That couldn't start because of the lockdown. And because of the lockdown, we resumed vaccination this month of November. Incidentally, the Delta is just starting at the brink of when we are about doing the mass campaign, vaccination that was planned for 20th of November for 14 days. So there are 6 days that are being planned for vaccination, which is to start on the 20th. But what we've done for Delta State with this outbreak in the particular LGA that is involved, the activity has been fast-forwarded. As we are talking, active vaccination is taking place in that LGA. Ika North is LGA with Ika North South is LGA. And then in the entire state, there will be a response from the 20th of November as earlier planned. So that has been the issue with regard to vaccination in Nigeria.
Well, Dr. Okosin, when you said that the people affected in these states are between ages 18 and 25 in one case, 18 and 30 in another, and the last case we had before 2017 was 21 years before 2017. I'm wondering, was it that we stopped vaccinating at some point within those years? If the number of people that are, the age range of people that had this disease, this recent time, this recent current outbreak, is between ages 18 and 25 and 18 and 30. Does it mean that we stopped immunizing at some point? What happened? What can explain that?
Okay, in Nigeria, before now, yellow fever was not a part of our routine immunization services. It was more of reactive campaigns, so that when once there's an outbreak or there's a warning, we go give vaccination. But now it is introduced since 2009, it has been introduced routinely into the immunization system of Nigeria and is supposed to be given to all children at the age of 9 months. So since that introduction in 2009, we've had it given to all our eligible children at 9 months, but before the age of 2 years. So we have always, since that introduction into the system, had it available for those children at that age group. And as we are talking, in all our primary healthcare facilities, secondary, tertiary hospitals, we have yellow fever vaccines available for our children to be immunized free of charge. It is, like you mentioned earlier, this was not a part of the routine system. And then the government realized the fact that with the increasing availability of the yellow fever vaccine, there was a need to protect the population, and that was the need for the introduction. And as I also mentioned earlier, We want to appreciate the government because in Africa as a whole, Nigeria is the only country that the government pays for its yellow fever vaccine for routine immunization 100%. And that is what, for that age group, we are confident of our children that were born since that time till now, that as far as they had gone to the facilities and received the vaccination, they are protected against yellow fever disease in the country. Thank
Well,
you. Over.
well, prophylaxis is not the only way to prevent yellow fever. You'll agree with me. Sensitization or education is also key. So, in terms of sensitization, educating people that these are the things you ought to do, these are the things you ought to watch out for, or otherwise, how much of that have you been doing? Because, yes, these vaccinations might not be available. I mean, the lockdowns affected the vaccinations that you wanted to carry out. But how much of education have you given people? Because for them to say it is strange, it means they probably have not heard about yellow fever before now.
Okay. I think, like you've said, we have a lot of IC materials that are also out there to explain to Nigerians what the disease looks like. And when you look at yellow fever on its own, it's also a disease that the initial symptoms of it, when it is not very severe, will look like a typical, sometimes that of malaria. It can even be confused with that of Lassa fever. It can be confused with that of Ebola and other hemorrhagic diseases that are available. So you see, it is when it now starts killing, because yellow fever, for those, 1 out of every 7 will become severe. And out of that 1 out of the 7 that is severe, 30 to 60% of them die. It is when the death rates are increasing and people are dying from it that people will now target this strange disease. Because at that point that the people are dying, they don't know exactly what killed those people. And that's why most of them, in my opinion, will call it strange. So the common symptoms of a yellow fever, once somebody is infected with yellow fever, most of the times, they will be asymptomatic. They don't show any sign. But for those that will show sign, it will be typical signs like sudden onset of fever, headache, body ache, nausea, vomiting, and then they could also have at a stage that, like I said earlier, 1 out of every 7 can become severe. Once it becomes severe, other signs will begin to come in. That is the stage where we will now have a very high fever. We will also have yellow skin, which is jaundice. And then at that stage, the patient might start bleeding. And then the last stage of it, usually, which will cause the death, is organ shutdown from shock. And then the patient will die. It is at that stage that most of the people will start seeing it as something terrible has happened in the society. We've been passing this information, and we'll keep on passing the information. And at the primary healthcare facility, we always encourage our primary healthcare workers during sessions, especially antenatal clinic, to give health talks generally to our mothers, our caregivers in the hospital before commencement of services. Thank you, and over.
Dr. Disu, you are head of risk communication at NCDC, and I remember Dr. Hekwazu, DG, saying that NCDC has scaled up risk communication to stem the tide of yellow fever. What does that mean, and how far so far?
Okay, risk communication starts with awareness about the disease, the danger it can cause, how people can get this, and again, what they need to do to protect themselves, and how they can suspect this when they see signs and symptoms, and then able to report immediately to the health facilities. And then this is what we do by engaging people, discussing this with them, finding out their concern. And so what SDC has done is they have sent a team of responders to these states that have been affected. And this team include risk communication officers who are also working with them, also working with the health educators at the state level and at the LGA level, and also community-based organization, community networks, religious leaders who are on the ground to identify issues and then be able to communicate this in a manner that people will understand, and then in a way that they will understand that this information is relevant to them, and then a way that they can take action. So it's a conversation that is between the people and the supposed experts who are discussing this. It's not just giving this information to them. And one good thing about COVID-19 is it has opened our eyes. It has been able to help us to also engage other partners, get more expertise about how to do things. And then with regards to our messaging, which is very key, for us to be able to adapt our messaging to the real needs on ground. The reality in Enugu State may be different from the reality in Delta State. So you have to confront the situation, address it based on the situation you find on ground. Of course, cultural practices are very, very key when it comes to this. Now, we need to understand how this disease is transmitted. It is transmitted by a species of mosquito, which is different from the one that transmits malaria parasites. And then where can we find these mosquitoes in our environment? In waters that are collected in containers. Sometimes this could be within our vicinities. And people need to know that they need to clear their environment and they need to do proper sanitation. Where do they dump their waste? How are they taken care of? And then they need to know about that. And then the signs and symptoms of this, they also need to know, just like Dr. Bassi has just mentioned. People need to be aware because ordinarily they will tell you it's malaria. Sometimes some people will even say, oh, it may be COVID. So there is this tendency that people will not want to go and report early. And risk communication is about rapid decision that you take, as in telling people quickly what is happening and then for them to be able to make informed decision. And that is what we're doing.
Right. Do you think that
the personnel on ground,
right,
personnel of the local government?
Would you say that we responded to yellow fever with the same zeal, with the same urgency as we did to COVID-19?
Yeah, when you look at the scale of the yellow fever and the COVID-19, when the disease outbreak starts, we do what we call risk assessment to know what exactly is required to address the situation. And based on that, we deploy resources with regards to personnel, with regards to materials, and then whatever we need, drugs, and so that will match the level of the outbreak. So because of the communities where this is happening, even when these personnel get there, they do community engagement, they focus on these communities. Meanwhile, there is still general awareness creation that the state will be doing through radio jingles, through televisions, through media talks, media appearances, just like what we're doing now. On our own social media handle too, we also do that. On our website, we also put out the information there. In case some other communities somewhere are having similar experience they don't know, probably because of the awareness about what's happening in Delta. That is why people in Enugu too could also report, especially this era of social media, and information travels so fast. So when people pick this and they quickly say, this is what is also happening to them, and the health authorities in the state will quickly go and respond to them. We also have the helplines that we use for COVID-19 is not only for COVID-19. It predates COVID-19. People call. We call it what we call dynamic listening. People call when they have issues, and then our agents who pick this call, they respond to them and escalate this to the surveillance department. They now call the states to go and do further investigation in case the states are not aware. And that is happening. There's also communication with all relevant departments who need to know about this, and so that they can also prepare for this. And then we're also working with stakeholders like WHO, UNICEF, and then as well as other partners, and the USCDC, and the USAID, and so on. And then we share this information with them because all of them, they also either have one program of interventions on ground, and they can mobilize personnel and resources to support the process wherever this is ongoing. So these are things that we are activating.
I understand.
Still fighting
I'll be honest.
It's also opportunity to infuse the messaging.
I'll be honest with you. I mean, the thinking in rural areas is that COVID-19 is elitist, which is why it's getting that much attention. I mean, you see the magnitude of attention that has been given and is still being given to COVID-19. And don't forget that the case fatality ratio for yellow fever is much higher than COVID-19. I mean, in some areas you have 31% for yellow fever, and for COVID-19 it's less than 5%. I mean, you remember what happened, the lockdowns, the call for PPEs, the panic and all that, which is why I ask, do you think we responded, or we are responding to yellow fever the same way we've responded to COVID-19?
Yes, we're responding. Let me give you an instance. Just last week, we had a meeting with all the state health educators in the country. And we told them that we are moving into a season where you're likely to have Lassa fever, meningitis. And we have even started developing a program, Lassa fever awareness program, yellow fever, and other diseases because of the season we're entering. And we have also told them that they too need to start doing that. So it's not just about yellow fever, but it's also about the priority diseases that we know that can rapidly claim the lives of the people. So we're doing enough, just like I told you. Based on the level of the outbreak, personnel have been deployed, the high-C materials, the resources they need, and assessment is an ongoing thing. And then as they need more attention, more hands, more partners, more resources, they will also make sure that they deploy. As we are doing community engagement, through the personnel on ground, working with primary health care agency, the state officials, and so on. Then we're also doing public communication for general public to also know about this in case this happens, or people that want to travel to those areas, or people that are living in those areas going to other parts of the country, and they need to know what precautions they need to take so that we don't spread this disease. Yes, this disease is spread by mosquito bite. If somebody has it in his system, and he goes to another place and the mosquito bites him, and then he can introduce it into a new population. Our major concern is how do we make sure that it doesn't get to like urban population where the level of immunity may be low because there has not been mass campaign there. For instance, Lagos, Kano, and you can see how people move within the country. That is why we also need to engage the local community. This is not the time for you to travel. If you want to travel, these are things you need to do. And then generally, we tell Nigerians, okay, these are measures that we need to take, and we need to watch out for this. And those are things that we are doing. It's all about informing the people, empowering them to be able to take informed decisions. Let them know the risks they face. What alternatives do they have? How do they take this decision? Giving them actionable information. That is what we're talking about.
This one is probably for both of you gentlemen, but I think it is also important to mention it. Well, just as my colleague said, we have had cases of yellow fever since 2017. The attention it has gotten hasn't been that severe. Well, you have given some explanation, Dr. Disu, but it's the same kind of attention that we haven't. That's the way some people will see it. We haven't given enough attention to Lassa fever, for instance, which we can almost always predict the time of year it'll come on. Now, that has been the story for successive years, and the case fatality averages about the same number, the same percentage every year. Why is it difficult for us to stem the tide of Lassa fever, which season is also approaching?
Maybe I will just come in here to also say the first question that was asked, why are we not giving the same attention to COVID? I can assure Nigerians immediately the information, the report came from Delta on Thursday officially that this is what is happening. The executive director, Dr. Faisal Schwab, immediately ordered a team from the national to be in Delta, to work with the NCDC team and the other colleagues that are there to respond with immediate effect. And by the second batch of the staff were at the Delta State. A part of the staff that were in Anambra on an assignment were in Delta the following morning by 8:30 a.m. By 9 o'clock, they were already having a meeting with the Commissioner for Health. In the afternoon of that same Friday, this Friday that passed, There was a state technical team to plan and develop an action plan for emergency response. That evening, the commissioner was briefed back, and immediately on Saturday and Sunday, there was micro-planning to respond. Monday, day before yesterday, the health workers and the community members were trained to respond. And as we are talking to you and Nigerians now, yesterday, the actual vaccination of the people in Idemusa and 2 other wards in Ika Northeast local government in Delta State started. Today, all the wards in the local government and then the neighboring local government commenced vaccination also. The Commissioner for Health himself, the National Primary Care staff on the field there, and the zonal office, about 13 of them in number, and the entire state team are on the 2 local governments today to ensure that the population of those 2 local governments, that is about 500,000.
Listen, we hear you, all of the responses. We hear you. Just a moment. All of the responses that your agency has given to this. But the question that I'm asking is, Lassa fever happens every year, and we don't seem to have been able to put a lid on it. We still have about the same number of fatalities every single year. Why do we still have that if we can respond? What is it that is responsible for the fact that we're not able to put a lid on Lassa fever? Look at this map.
Now,
Okay, I think it is a collective responsibility by all. Because diseases occur in people, and the attitude of people, the characteristic, the way they live their life, what they do because they want to earn living, influence how these diseases move around. For Lassa fever, it has been with us for decades, and we've not really focused that attention. Not just the government, health authorities. We need the private sector to come in into this game, into this space, to play their part. The community themselves, because Lassa fever is all about environment, because primarily it is transmitted by rodents. And you know what attracts rodents are death. And so if environmental sanitation is properly done and it's supervised, and resources that we need to do this is there. If you look at across the nation, how many environmental health officers do we have in each local government? How many of them have the resources to do their work? Those days, they call them in the southwest, wole wole. They move from house to house.
Of government in control. Just a moment, Dr. Disu. Just a moment, Dr. Disu. Such an agency as yours is in charge of disease control, okay? Now, many of these, local governments and all of them that you have mentioned, they are supposed to have environmental sanitation officers. That's what existed for many years before now. What has an agency like yours done to create awareness about such a thing at the local government level to ensure that the right things are done? And then you maybe speak with the governors and the rest of them.
Okay, sir. Yeah, so first thing is in NCDC, NCDC has a mandate to protect the health of Nigerians. This mandate is achieved by leveraging on the mandates of other MDAs, their resources, their structures around the country. That is why in NCDC, when they want to activate a technical working group or EOC, it is usually multi-partner, multi-agency, multi-sectoral arrangement to make sure that everybody comes on board. And that's exactly what we also have for Lassa fever. Ministry of Environment is represented in the current Lassa fever technical working group that we have. And then the National Primary Care Development Agency, they are there. And then also National Orientation Agency, and so on and so forth. So now, when you now agree on what to do, when each agency or MDA are not supposed to play their own part, some of these agencies may have limitations in doing their own part. For instance, when it comes to the role of environment.
I apologize, we are completely out of time now. Well, you have given us some ideas of how this should be addressed, and hopefully we will do the needful to ensure that we do not have unnecessary deaths of Nigerians on our hands as a result of diseases or outbreaks that we can control before they control us. Dr. Yaya Disu, Head of Risk Communications Division, NCDC, as well as Dr. Basio Posen, Director, Disease Control and Immunization, National Primary Healthcare Development Agency. Thank you, gentlemen, for your time this morning.